Thank you. And I had to pull a lot of strings to go after Michael. You know, there's nothing like, I think I'll take him with him every time I speak now. There's nothing like speaking to a room that's just been mindful. We'll switch gear a little bit. What I wanted to share with you today is some perspective about the work that we do as CHAI. We work with countries all around the world, primarily in Africa, but also in this region. And what we do is work with governments. We're not there to implement our own systems. We're there to help governments take leadership of their health system. And one of the very important questions that governments are talking about right now, that one of the big buzzwords in public health, is universal health coverage, UHC. So I'll say UHC a couple of times, hopefully you know what I mean. When I thought about this conversation, I think for us all in Australia, the real question for us is what can we do from Australia? And when we think about the health system in Papua New Guinea or in Ethiopia or in Malawi or in Rwanda, it can feel very removed, but there is a lot that I think, a lot of goodwill and a lot of energy and a lot of, I've seen that over the last few days, a lot of real interest to see what we can do. So in the spirit of what Michael did, why don't you, as a little practice, take a quick second and write down for yourselves or tell your neighbor or jot it down somewhere. If you were to think about the one thing that Australia has to contribute here, what would you say it is? And let's revisit that in a second. So just take a quick 10 seconds to think about what is it that Australia can contribute to countries that are trying to move toward UHC. And let's see if we can later on revisit that. While you do that, I've spent 10 years in this field and then some more, and to me, the synthesis of what my recommendation or suggestion or motto will be don't dream, don't despair, and focus on a solid foundation. And today we'll walk through a little bit how that applies to getting to UHC, getting to health equity. But over the last couple of days, I've had a couple of interesting conversations with many of you. And to me, that applies more broadly. It applies to your own career. You know, when you, as a student, thinking about how on earth am I going to get a job? How on earth am I going to do whatever? It applies to almost any public health problem or any problem that you look at. And we'll get to it a little bit, but I think that maybe not all of you will get to work on helping Ethiopia develop a health insurance for the country, but all of you will get to work on really important questions, and that perspective can be very useful, I hope. So, I moved here with my family from Australia about a year ago. I grew up in Israel, hence my accent. I lived here for 11 years, and then I moved to the US, and I lived in Africa, in Congo and Senegal. My accent is banged up from all directions. But coming here has been really stunning, really, really striking in many ways. I remember I drove with my wife back from the swimming pool where my kiddos went swimming, and we were just stunned at how lucky this country is. You know, it's really so wealthy. There's so much wealth and so much organization. Everything works, everything functions. And when you've lived in places that really do not function, it's really, really striking. It's, you know, we're just joking that it's kind of the milk of the land of milk and honey. You know, so much. We're so lucky here. And then when you look at public health, no wonder Australia, in a recent survey of 95 countries over the last 25 years, Australia ranks as number 6 in terms of health access and health equity. But then it's very tempting to think that it's about money, right? And Australia's economy has done very well. And it's very easy to say, oh, we just need every economy to do very well and then it will be okay. But then you look at the same survey at the US, and the US has got a GDP that's 20% higher than Australia, and the US spends twice as much on public health, and they're ranked number 35. So it's not just about money, right? Money helps, but it's not just about money. I actually started my work in public health in Tanzania, and we were working at the time to help the government of Tanzania think about how to increase the number of doctors and nurses in Tanzania, because it's hard to get access to medical care if you don't have doctors and nurses. It was a pretty hard it was a pretty hard picture. Tanzania has 30 doctors for every million people and 428 nurses. It's a huge difference. And we were working with Tanzania to help them figure out how they can grow. And there was an element of despair in that for me. And also an element of dreaminess. So at some point I stepped back and said, even if we trained all these doctors and nurses, how is Tanzania going to pay for them, right? Where is the money going to come for the salaries? And a part of me, I was working with McKinsey and Company at the time as a management consultant, and a part of me said, you know what, I should just forget about this public health. I should go and find oil for Tanzania, right? I should go and find shale. I should develop a IT sector for Tanzania or call center, because then they will get the economy going, and then they will use their money to train and pay for doctors, and then this will be done, right? And so it's very tempting to dream and just say, if only we had money, if only Tanzania had oil, if only we had a tech sector, everything will be okay. And it's very easy to despair and say, look at where it is, look at where public funding and donations and public donor assistance for health is going. But then you look at a country like Angola and Rwanda. And I apologize a little bit. I know that in this context, Africa seems a little far, and the focus in Australia tends to be more on the region. And we do also work in this region, but a lot of my work has been in Africa. Angola is a country that did discover oil. They were lucky, or they thought they were. And their economy grew tremendously. The GDP per capita there is 4 times what it is in Rwanda. In fact, the wealthiest woman in Africa is the daughter of the president of Angola. And she has $3 billion to her name. It is a very, very wealthy country. Rwanda is a small country, very agrarian. It's a gorgeous place, a land of 1,000 hills. Very poor, 25% of the income of Angola. And yet, if you look at health indicators, a child is 3 times more likely to die before their first year of life in Angola, not in Rwanda. And a woman is 60% more likely to die in childbirth in Angola than Rwanda, despite the money. So don't dream about finding oil. That's not going to be the silver bullet. And don't despair that your economy is only $700 per person. There's a lot that you can do within that. Anyone cares to guess what the number for Australia is for maternal health? 6. Still higher than it should be in some ways, but so much better. So, go back a second. Don't despair. What should we do then? Right? We work with these countries to help them figure out how to go from where they are towards a place where every mother has access to safe delivery, so you don't have 477 deaths. And it's very easy, by the way, when you work in public health to just think about stats, right, and numbers. But this is not numbers, right? These are 477 women who will not come home with a baby, but will not come home at all, right? And for me, when I think about that, I always think of when my second child was born. I have 2 kiddos, 5 and 7, and I kept me and Luca stayed at home, and when Teo was born, we were trying to trick Luca, who was 2 years old at the time, to accept the baby, right? Because it's simply rivalry type of thing. So you want to take your older kid, and they discover the baby themselves. So you're not imposing the baby. Like, you take them to the hospital, and they see this kid, and they go, "What's that? It's almost like a new toy. Can we take it home?" "Okay, fine, if you really want to." As opposed to, "This is a new brother." And so, I stayed at home with my I came home after Teo was born, then I took Luca there, and he came to the bassinet, and it worked. He was like discovering this little baby. And to date, my favorite photo of the two of them is 2-year-old Luca holding this baby, and kind of with that face of, "Can I take this home?" And when I think of that, this is what it means. It means me and Luca staying at home and, right, nothingness. And it is devastating. And it's so important to remember that this is what public health is about. This is why I am so passionate about this, and I care about this work. And it's important to remember and take that step back and think about it. So, how do we get there? Focus on practical measures and help countries establish solid foundation for where they need to get to. And we're doing that. We're working right now with a number of countries primarily in Africa, also in Asia, to help them think about the 10, 15-year time frame and how they get to universal access. And there are 2 pieces that you want to do that. One is you want to think in advance about the end state. It's very tempting to start from where you are and just take one step at a time. You know, they say that a journey of 1,000 miles starts with a single step. Well, that's true, but you also want to know where you're going, and that's very important. And then you want to focus about the pathways and practically what do governments do? What can Malawi do right now? What can Ethiopia do right now given where they are? Let's walk through that a little bit to talk about what that means. When we talk about focusing on the end state, what we want is Australia, not the US, right? So that number of maternal health in the US is double what it is in Australia, right? Still much better than Rwanda or Angola, but don't forget that they're spending twice as much per person, right? So that system is incredibly inefficient and does not show the results. And what we want to do is we are not going to have a whole lot of money to play with in Ethiopia and Rwanda. We want to make sure that every dollar goes in the right way. We don't want to go there. So we want to aim to an end state that looks more like Australia. We also don't want to look like South Africa. South Africa obviously has a history of apartheid and a whole lot of political situation there. 17% of the population in South Africa has access to private health insurance. Those 17% use up half the resources in the country for health, right? So it's a very bifurcated system. You know, it's two systems, and it's not where you want to end up because there's a lot of wealth in society that is not going to everybody. What do you want the system to look like? Well, thankfully, there's been a lot of experience in this, and there's some key principles that are very useful to keep in mind. So you want a system that raises revenues progressively, and that's technical terms for basically saying the wealthy should subsidize the poor. You know, it's not rocket science. If you have a lot more money, you should be contributing more. And in fact, the simplest way to do that is through the taxation system. Despite the fact that some people would like to pretend that a flat tax would work, even here, most taxation systems around the world are fairly progressive in that they take more from those who have more, and then they share that around. You want to avoid out-of-pocket expenses here, and I'll revisit that again and again and again to drill that into you. Out-of-pocket essentially means that I go to the facility and I pay for whatever I have, right? So if hypertension drugs are $100, I have to pay regardless of whether my income is $200 a year or $20,000 a year, right? So it's very regressive. You want to pool the coverage broadly. And essentially what that means is that the healthy pay for the sick, right? So it means that most of you in this room are fairly young and hopefully fairly healthy. Ideally, you're all putting into the system, and in Australia you do that through Medicare levy, right? So that those members of society that are sicker and need to utilize the limited resources more intensively can have access to it. And so when you're older, when you have a child, or when you develop some disease, you have access to that as well. Quick story on there. When we started doing this work, we looked into a health insurance scheme in Nigeria, which was a voluntary system, a big no-no. Essentially what happens there is you can decide to join the system or not. The insurance costs $30 a year. It's not too much. And it covers a lot of stuff. One of the things it covers is hypertension. And the cost of drugs for hypertension are $144, right? So that works, the mathematics works, so long as you have 2, 3, 4, 5% of the population with hypertension. Everybody pays $30, some people take $140 out for drugs. What happens if it's a voluntary system is that if I'm healthy, I'm much less likely to stay in the insurance and re-enroll year 2 because I don't necessarily get the benefit. If I have hypertension, I'm definitely going to stay. And if I'm not in the insurance system, but my neighbor has hypertension and I do as well, well, I'm going to pay the $30 a year and get my $144 worth of medication. And so over time, you have a concentration of people who are sicker than average. And so you have essentially a small pool. So again, you want society as a whole to take care of the sick, and the way that you do that is through making sure that everybody contributes. And then you want to purchase services very efficiently. You basically want to make the most out of the money that you have. And that means not getting to what the US looks like. It's actually not about out of pocket in this one. How do we get there? What are some of the steps? So the first step is really to invest in the health system. And that can be a little counterintuitive because a lot of the time the feeling is there isn't a lot of money, let's just do more with what we have. But the reality of it is that to get a system that functions well, you need goodwill. You need goodwill in the population, you need goodwill in parliament, which is a lot of time where these things happen, and you need to make sure that people who buy into the system in one form get to the hospital and there is a doctor there, there is a nurse there, there is a drugs there, and that's really, really important. You want to bridge the funding valley of death, and I'll talk about that a little more in a second. So actually, I'll skip that for right now. I'll come back to it. And you want to set up a solid financing system. And to me, this is actually where Australia has a lot to contribute. So I'm not sure what you wrote down when I asked you to write something down, but a lot of people think about money, right? They think about Australia. We spoke in the break before about the campaign for Australia global aid. And Australia is not given nearly as much in funding as it should, right? But even if Australia doubled or tripled or more the amount of money that it gives for health, it will be a drop in the bucket, right? It's tiny relative to the needs. To me, what Australia has to give is experience and knowledge and insight and technical advice. Australia has a fantastic, absolutely amazing health system. I went recently to get my skin check. You know, I grew up in Israel and Australia, and with my skin type, it's two of the worst places to grow up. So just a routine skin check. I went to the doctor, got my skin check, went back to the receptionist to figure out what I need to do, and she was like, no, you're good. And I went home. So she had my Medicare card, and everything just functions. Everything just works so smoothly, right? And the revenues are raised progressively. If you earn more, you pay Medicare surcharge, which is great, which is really good. If you're lucky enough to earn more, you should be subsidizing others who are not as lucky as you are. If you're sick, you have access, and it's all just so smooth. In the US, that process can be so painful. And in many countries, by default, the simplest thing to do is to just ask the facility to charge or let the facility charge someone. So if I had to check myself for skin cancer or do anything else, I would pay the facility. For someone like me, it's not a big deal, right? But for a farmer that has very, very limited income, coming up with $3 to check that child cough to make sure it's not TB, that's a big expense, right? And setting up a solid financing system is very tricky. Literally, my first experience in this in Ethiopia was walking up the building of the health insurance agency that we are helping them to set up. It was a 10-story building. There were no windows. It was just being constructed. There was no electricity. We had to walk up 10 flights of steps because the elevator wasn't working yet, and there was no IT. And it's getting much better, right? But it's literally that. It's setting up the agencies and the infrastructure that makes the health system work. And it's not as sexy as opening up a clinic, right? It's not as sexy as going and building a house out of bricks or donating drugs. And I used to do that as well. We still do some of that. But it is really what will help countries in the long term to get there. Let's talk for a second about the valley of death. What happens here is when countries are very low income, they get a fair bit of their funding from donors. And we as a global community have done very well. Global funding for health has gone up massively over recent years. And countries like Malawi receive something like 60% of their health funding from donors. And Ethiopia also about 30%. In some areas like HIV, it's up to 90%. But then as countries' income grow, donors begin to pull back. And then countries are not yet in a position to catch up, right? So their income is high enough to not receive that much funding, but it's not high enough to capture that growing health in society through the tax revenue and then pay for facilities. I figured that, if the title says when donors pull out but your taxes are still low, you need a little something, like that. So I tried to do a little, there you go, jiggle a bit. So this is what we call the valley of death. And a lot of countries in this region actually are facing it because the income goes up. Often it's not very well distributed. We spoke about that with the folks in the room earlier on. You see a lot of countries where there is health, but not everybody has access to it. And then countries really struggle. And then what tends to happen is there is more wealth in the society. The government is not able to capture that funding, but the expectations from the health system and the willingness to pay grows up. And so you see out-of-pocket expenses coming in. And there's a couple of more slides that show that country by country, but you see that in low and then as countries become low middle income countries, you have more and more out-of-pocket expenses, which is a real danger. It's easier to do than setting up a health insurance agency or a Medicare equivalent, but it is really dangerous because it means that the people who are sickest and poorest are impacted the most. And it discourages use quick stats. 100 million people globally are driven below the poverty line because of health expenses, because the system functions such that you have to pay out of pocket. So, with all of that, how do we help countries get there? What is the pathway? If we take a step back and look at all these pieces, you help countries build a robust health system. You help them build the facilities where they need them. You help them train health workers and build up the supply chain. You make sure that their health services are there so that people who have TB go through the right process so they don't develop MDR-TB. MDR-TB is awful. I was in Chennai a couple of weeks ago in India, and so a patient come in and get his regular visit, comes out with a bag of medicine, and it's like enormous. It's 17 different types of pills in there. And I asked the nurse there, is that like a week or a month supply? She said, no, this is 3 days, right? And they have to take that every day for 2 years with awful side effects. And that is because we're not managing the current MDR well. So you want your health services to be solid there. You want sufficient funding, so you want to help countries, especially as they go through that dip. And there's some very interesting, innovative financing ideas that can be used. And you want to think very carefully about how much funding is needed and how you get there. And then you want to help them build a robust health funding system. And again, if I had my wish and I spoke to the federal government and said, how can Australia help? I would say, don't worry about sending money, but figure out how we've done Medicare so well here, and let's help Ethiopia get there. Right? Let's help Rwanda get there. This is a woman in Rwanda with a health insurance card. And Rwanda has reached something like 97% coverage of health insurance. It is stunning. And by health insurance, I don't mean the private health insurance that we talk about in the US. I mean something more like Medicare, social health insurance or community-based health insurance. And there's a lot of pride in that. I spoke to a guy who worked with Jakarta when Jokowi introduced health insurance there, and he said, people are really proud of the health insurance card because it symbolizes something, right? It symbolizes, it's almost a spiritual, artifact of this is society coming together to say that I am entitled. Doesn't matter what my income is, doesn't matter what my skin color is, doesn't matter how old I am, I have the right and the ability to access medical services. And we as a society decided that that is to be equitably distributed. So, don't dream, don't despair, and focus on a solid foundation. Don't be too worried that in this context, the country doesn't have oil or a tech sector. In your context, don't despair too much that the situation you're facing is so challenging as to seem hopeless. Don't dream that you will find oil or tech sector, that you'll find a magic bullet, because that is not what is needed in most cases. We don't need a silver bullet. We need to focus on the fundamentals and solid foundations that will build the long-term solution. And work with whoever you're working with. In our case, we are very consciously working with the Ministry of Health, with the government, because we know that we can go in there and start a facility, or we can go in there and start a program, but at the end of the day, 10, 20, 30 years from now, it is the government, hopefully a democratically elected government, but the government of the people that will look after the health of the population. There's a lot in what I've just shared in every piece of it, and I'm very happy to talk more to any of that now as questions or over time. It's a beautiful, rich, challenging experience to try and work with countries and governments to get there. And it's a privilege that we all have, to have the education and to have the resources and to have the skill set that we have, we as a society, and then we here in this room as individuals. And so it's a privilege to be able to use those skills and that positioning that we are lucky to be born into, to try and make the world a slightly better place in whatever way you're focusing on. Thank you very much for having me, and thank you for the time.